open is on the right because our laryngoscope, again, has to be in the left hand. And we have suction on the right. So I activate the light, extend the C-spine. Now if the neck is stable, if the neck is not stable, then you can't do that. The only way to get the mouth open is to do what's called a jaw thrust. You get up underneath the angle of the jaw and pull forwards. You see how the mouth is coming up? That's a way to intubate with a C-collar on, or if you're not sure about whether or not the C-spine is stable. All right, we got a stable C-spine, so we're going to extend the neck, turn the light on. Now, don't just bury this thing to the hub. What you're going to do here is, remember, is they're in arrest. The tongue is just falling against the back of the throat, and their mouth is closed. So you're going to have to use your right hand to open their mouth, and you're going to have to use the blade to direct the tongue. So you kind of come over to the side and grab the tongue, and then just work this, and so it's in the middle of the tongue. The difference between a straight and a curved blade is that if this is the tongue and this is the epiglottis, remember the larynx is right on the back side of the epiglottis. So your objective is just go right back down the back side of the epiglottis. A curved blade goes in the vallecula between the tongue and epiglottis. A straight blade gets the epiglottis. So in a straight blade, you can just jam it in there, lift it, and pull it back. In a curved blade, you sort of have to walk it down the tongue. Okay? I'm going to get a chair so it's a little... All right, so it's pretty easy. Just don't slam it all the way in there. Just walk it down, and you'll start seeing, there's the epiglottis right there. You can see it right there. Now here's the thing. Don't pull back. Because if you pull back, you're going to break the teeth. What you want to do is you want to push in the direction of the handle. You want to push it and then rotate your wrist. You want to push it. Don't pull back. Push it. So I'm going to push it, and I'm going to, oh, look at, big as Dallas, right there. And I'm not touching the teeth, the upper teeth. You might have to put your forearm on the face to help keep the head down. So I would suction it. Then take my ET tube, and this is a direct visualization. I'm watching this thing go between the vocal folds. There it goes. Just like that. I put it into about 21 centimeters, hold it, pull the stylet, inflate the cup, check to see if I'm in. As I compress the bag, you know, I can put a CO2 detector here, compress here, have somebody listen to the lung fields, and we're good to go. If I'm in, then there are all sorts of commercial products that are used to attach the ET tube to them. Right? So this is just a Velcro strip. All right? Now we're good to go. To extubate somebody, it's very simple. It's just deflate the cuff, and if they're breathing on their own, when they exhale, pull it out. Okay? And that's how to do it. You just got to remember that on the laryngoscope, you push and rotate your hand. Don't pull back. Now, there's one other thing you can do. If you can't intubate through the oropharyngeal route, there's a nasotracheal intubation. to nasotracheally intubate somebody, get a smaller tube, like a 6 or a 7. Here's a 7. You want to put KY jelly on this for sure. You want to lubricate it up. You cannot use a stylet when you nasotracheally intubate somebody. And this is a blind intubation. In other words, you're not watching it go through the vocal folds like you do with an orotracheal intubation. So what you do is, this is lubed up. You do not extend the neck. You put this perpendicular to the floor of the nasal cavity and just advance it like that. You can help yourself by flexing the neck if you've got a stable C-spine, okay? And just advance it to see if you hit the right spot. It will help you maintain that curve. If you tie it in a knot like that, get it right there. I got so much glycerin on it. There you go. Put it in ice water for 2 minutes, and then when you unfold it, it will stay curved. That will help you with the curve. There's another thing called a whistler, which is what this little thing is right here. If somebody is breathing and you just want to get them intubated through the nose, you put this little thing on here, and as you advance it, as they breathe out, you'll hear a. So as you get it down into the trachea, you should still hear it whistle. If you go into the esophagus, the whistle goes away. And you know you're in the wrong pipe. Okay?
How do you move it if you're getting the wrong pipe? How do you adjust it to the right one?
Pull it back up and try it
Just
again.
try again?
Yeah,
Just
try it again.
Trying?
Mm-hmm. Now, when we do the cadavers, we have all sorts of things called king airs and glide scopes, all these fiber optic things you're going to be using, all these video things you're going to be using to intubate. But if you're out in Sulphur, Oklahoma, or Buffalo, you're not going to have those. So you know how to intubate. You need to know how to intubate this way. Now, one thing about nasotracheal intubation is, why would you do it? Well, one reason to do it is if you can't find the mouth. If somebody's tried to blow their head off and you can't find the mouth. The other thing about nasotracheal intubation is you don't do that if there's a suspected basilar skull fracture. You don't want to intubate the brain directly. It doesn't work that way. Okay, one other thing I want to show you here is a thing called a bougie. Bougie, B-O-U-G-I-E, or hockey stick. It looks like a hockey stick, right? The little turned-up thing. If you can't get somebody intubated, if it's too hard to get them intubated with this, if you just can't seem to get them intubated, then what you can do is take this little hockey stick and get in there. That thing goes down real easy because it's so small. And actually, when it's in there and you lower it and you raise it, you can feel it go as it goes down the tracheal rings because of that upturned hockey stick. So now that I got this thing in, well, now all I got to do is take my endotracheal tube, put it on there, and push it down. I'm in the trachea. Okay? So, you can practice on a bougie. We'll have these when we do the cadavers, so you'll be doing those. You can feel the tracheal ring. Okay? Let's see, this thing right here. This is not exactly what I'm looking for. It's called called a nasal trumpet. It's like a little thing like this. And all you do is you slide it in the nose right there, so that instead of having to use an OPA that would activate the gag reflex, this nasal trumpet gives you an airway. Okay? All right. Any questions about intubation? Now, this little baby here, when you intubate this little baby, be very careful because it's hard to intubate. You're going to need to get down on your knees and get down in there because the head doesn't extend beyond that, obviously. Okay? All right, so let's change gears and go to the life pack. There are different types of life packs or defibrillators here. They're monophasic and biphasic. If you'll notice on your algorithm sheet there at the bottom, it says biphasic or monophasic. This is an old monophasic machine. And by the way, I'm going to tell you right now, I'm putting it on record, this is a live machine. I'm going to leave this here. Do not shock each other with this. Don't kill yourselves with this machine. When you say clear, you better clear. Okay? All right. I saw, this is a monophasic machine. When you hit the energy level, it goes to 360 joules. A biphasic machine won't go any further than 250 joules, most of them 200. And it has to do with the way energy is delivered. Biphasic machines are more efficient at focusing the energy. All machines now are biphasic. All AEDs are biphasic. This machine is a monophasic machine because it goes to 360, and this machine is probably older than most of you. But because of this LifePak 9 was such a workhorse, there are still these out there. So if you're going to shock somebody, you need to know, is it a monophasic or a biphasic machine? And simply turning it on will tell you. If it goes to 360, it's a monophasic. Okay. So one time I was teaching ACLS, and I went to the restroom to empty out this cup of water we use for intraosseous needles, and when I came back, these third-year orthopedic surgery residents were sitting around in there, and one of them shocked the other one on the calf with 10 joules and knocked him out of the chair. So that was 10 joules. 360 joules will burn your skin. Bright red. It's a nasty second-degree burn. Okay, so don't be careful with this machine. Okay. So let's go over the pieces and parts. First of all, when you hook somebody up to a monitor, all monitors come with these lead wires. These lead wires are coming out of the front of this machine. The lead wires, there are 3 lead wires, and on the back of the lead wires, it's embossed R-A-L-A-L-L. So it's right arm, left leg. And what you do is you don't actually have to put them on the arms and legs. As long as you put the right arm in the right pectoral region, the left arm in the left pectoral region, and the left leg below the diaphragm, just stick it on the abdomen, you're good. And it'll give you this picture. Okay? Now, while there are 1,000 different types of these machines, they all basically have the same functions. One of them is that most people do not use paddles anymore. They use pads, like the AED pads. You run the code without actually having to hold anything on them. You stuck these pads on. But for funsies, we've got the paddles here. Now, the paddles and the pads are the 2 plates of a capacitor. When you charge these things up, that means that the energy on one side wants to get to the other side. Therefore, do not bring them together. Do not bring them close to each other, because if they arc, you're in the middle, you're going to get arced on. And since you're grounded because you're standing on the floor, you're going to receive that whole 360 joules, or 260. So never bring these paddles together. Never do what they show you in the, never do that. Never do that. Okay? If you had conducting gel that you need to get on the patient, you squirt it on the patient and do like that. Never never turn to your nurse. What do you think we need to do next? Take charged paddles and point them away from each other to the floor. Okay? One has apex on it, one has sternum. The sternum just goes over the sternum, maybe a little bit to the right. The apex goes out in the mid-axillary line on the left. If you cross them, you will still shock, but the wave will not defibrillate the heart. So you gotta get them right. Okay? There are two buttons. You press both buttons at the same time, or nearly the same time, and it will discharge. If you press one button, it will not discharge. You gotta press them both pretty much at the same time. You can shock somebody without gel, as I have done, but as I said, it leaves a perfect rectangular burn mark that when they wake up, that's the thing that hurts the most. Their chest is on fire. There's a charge button here, and there's a charge button there. So if we're going to charge in VFib, if we have a patient in VFib, if we're going to shock them, the first shock is at 360 joules with a monophasic machine. In a biphasic machine, the first shock is at 200 joules. So we're going to increase our energy level to 360 joules. All right? You're going to hit the charge button. Now we're doing CPR on this person. We're doing CPR. Okay? Right there, I'm amping up to 360 joules. I have hot paddles now. Okay? So what I would do here is, you're doing chest compressions. Okay, everybody stand back. I put the paddles on. I look around to make sure no one is touching the bed. I'm clear. You're clear. Everybody's clear. Discharge on 3. 1, 2, 3. And you see the spike. It didn't show up. Because this is rubber, that's why they well, it's not showing the spike. Usually there'll be a big spike when this thing discharges, okay? The patient does not flop around. They might do a little twitch like that, but they don't flop around like you see on TV, okay? But be prepared for a little twitch. Now there are other buttons here that we should probably talk about. One of them is, there's a lead select button here. These things are programmed to be in lead 2. So if for some reason you want to change the lead, you can do it with here. If you can't get the lead wires to stick on the little clippy things, you can actually record off of the paddles. You can record off paddles. Oh, this is so cold. There. I'm in VFib. All right, but the normal lead is lead 2. The EKG size, if I go back to normal sinus rhythm here, if a patient comes in and you hook them up to the monitor, and this is what you see. Low voltage QRS. What did we say from anatomy? What are 3 reasons to give you low voltage QRS?
Tamponade.
Cardiac tamponade. Obesity and emphysema. Obesity, emphysema, you have a lot of dead airspace. Remember that you don't have obese people in this state, so it's not something you typically see. But if you get somebody in and they have a low voltage and you need to artificially increase it, you can do it with that. Heart rate alarm just is for the nurses to, If it goes above or below this set limit, this machine will start yelling. There's a record button here at the beginning of a code, and biphasic machines now, it's electronic, but it has a paper thing right here. So at the beginning of the code, you hit that record button and let it just stream the paper on the floor. At the end of the code, they'll cut up that thing into 6-inch strips and put it all in the patient's chart. That is your anti-lawyer device right there, because it will show every shock. The nurse will, if you give epinephrine, will note on the strip epi given. So that's your summary of what happened. Okay. You know, in a code, if you're running a code for an hour on a little 4-year-old, you're going to have a mound of paper on the floor. Big mound of paper. So expect it. This machine has a pacemaker on it. If you turn the pacer on, it's going to start shocking at 60 beats a minute. This thing right here, what you do, is you turn the amperage up on the pacer until it captures the rate, and then just leave it. Okay? Understand that if you're shocking somebody 60 times a minute with this, it's going to be painful. If you look at bradycardia, the last thing on the algorithm is pacing. You can pace with one of these machines, but it's temporary until you get a transvenous pacemaker in. Okay? Any questions? Any questions about anything?
Are all of these going to be here? Is there anything that's not going to be here?
I can leave it all here. Yeah, I can leave it all here. Don't steal my shit though, girl.
Do you have the blades for the baby?
Yeah, you have the little blade right here for the baby. This is the one that works on the baby. So remember, upside down in your left hand. Okay? Just leave the baby stuff right. I mean, these things right here just belong to the baby. There's your little baby BVM. There's an adolescent BVM that's midway between these two sizes. Okay? So, now, what we want to do is, Kendall, what we're going to do is we're going to run a code. And why don't we... Now, during a code, it's perfectly fine to run a code with the BVM. But if you can, if you are skilled in the technique, then you can intubate it. So we'll act like we're skilled in the technique, and at some point we'll intubate. When you intubate somebody, the little trick is take a breath. Because when you gotta breathe, means they gotta breathe. You don't have them intubated, stop what you're doing, bag them a few times, and then restart it. Okay? All right, so what we'll do, let me go ahead and get you a here. Okay, you pull on the, all right, so what we're gonna do is we will give you a scenario. Your instructor, at the end of the day, will give you a scenario. The first day of your first rotation, they tell you about a man that was admitted last night for pancreatitis. He was stable. He's up on the ward. We've got an IV in place. We've got NG suctioning for gut rest. We've got him on some pain medicine. We're just watching him, like a Ransom criteria, number 2. He's just overnight. Just hopefully he'll perk up today. We can send him home. Why don't you go up there and do the progress note on him? So your first day of your first rotation, you walk upstairs at 7 o'clock in the morning, or 8 o'clock in the morning. You turn on the light. Mr. Smith, I'm here to do your progress note. And he does not respond to you. Oh, no. So I go over to Mr. Smith, I'm gonna do a sternal rub, because maybe he's sleeping at 8 o'clock. Mr. Smith, I notice he's blue. And I notice his IV is infiltrated. In other words, blood is backed up into his IV, meaning it ain't going the other way, right? So there's no response to this. I'm checking a pulse. As I'm checking a pulse, I'm looking for respirations. There's neither. I call for a code, and I start CPR. 30 chest compressions, followed by 2 ventilations, right? 1, 2, 3, 28, 29, 30. I just happen to have a BVM in my back pocket. So I'm going to give 2 breaths, and they go down. His chest rises. Okay, 30 to 2, while the code folks are coming. We get the crash cart there, we hook him up to a monitor, and that's what's on the monitor. What's he in? He's in VFib. First thing I'm going to do, this is unwitnessed VFib. I did not witness him go into VFib, so the first thing I want to do is shock him, right? So while I have some help here, come on up here and help me out. Just pretend to do the chest compression. And you'll do this in pairs, by the way. So she's doing 30 to 2, 30 to 2, 30 to 2. I'm going to turn on the machine here. This is a monophasic machine, so I'm going to go to 360 joules. I'm going to hit the charge button. So she's doing 30 to 2. Kind of good a little. There you go. Okay, so warming up here. I'm having the paddles. We're charged. Okay, everybody clear. I'm clear. You're clear. Everybody's clear. Discharging on 3, 1, 2, 3. So after a shock, I want you to resume chest compressions for 2 minutes or 5 cycles at 30 to 2, right? 8, 29, 30. After 5 cycles, I'm going to reassess. Check the blood pressure. Check for pulse. Check the monitor. He has no pulse, no change on the monitor. Resume chest compressions. I'm going to shock him again, right? So shock again, right? Keep going until I tell you stop. You don't want to get off the chest for more than 10 seconds, right? Okay, I'm charged, you ready? Everybody clear, I'm clear, you're clear, everybody's clear, shock on 3, 1, 2, 3. Okay, resume the chest compressions. Again, for 2 minutes, 5 cycles. Okay? This is the 5th cycle, 9, 30. So we're going to bag him. Check a pulse, no change on the monitor, resume chest compression. I need epinephrine, 1 milligram, push. It's in, she's circulating it for about 30 seconds or so. I'm going to charge up. The drugs will never convert them, it's the electricity. Okay, so we're charged, okay, back up. Everybody clear, I'm clear, you're clear, everybody clear, shock on 3, 1, 2, 3. Okay, resume chest compressions. Again, 2 minutes, 5 cycles. Now, we're going through this fast, but 2 minutes is going to seem like a freaking eternity when you're actually doing it. Okay? She needs to be looking out for somebody to relieve her every 2 minutes, because doing chest compressions, as I said, is hard. That's the 5th time. We check the pulse, check the monitor. No pulse, no change on the monitor. Resume chest compressions. We need 300 milligrams of amiodarone. Push it in. Get it in. She's circulating it, right? You just can't put it in and go. She's got to circulate to the heart. We're going to charge it again. Keep going. Now we could intubate here. If there's, I forgot to mention, if the IV was infiltrated, we got to start an IV or put an IO in. Okay? So 360. Everybody's clear. 1, 2, 3. Bam. Okay? We got a change on the monitor. Go ahead and resume chest compressions. You want to still do chest compressions for 2 minutes or 5 cycles, even though we have a change on the monitor. Give me some PVCs. Okay, we've got some ectopy there. You see the PVCs? All right. So at the end of 5 cycles, he's still not awake. Let's check pulse. He has a pulse. It's around 40. What's the blood pressure? blood pressure we'll say is 80 systolic. Okay, I want to give him 0.5 milligrams, so he's got a pulse, so we don't need to do that anymore. It's over 40, so we don't need to do that. We're going to give him 0.5 of atropine. Give him 0.5 of atropine, give him a liter of fluids for his pressure. We're going to reassess him here after a couple of minutes. His rate should come up. His rate is now at 70. What's his blood pressure? Anytime you ask what's the rate, the next question out of your mouth is what's the pressure? Rate alone does you nothing. It does not determine perfusion. Pressure does. So pressure is the important thing. What's the pressure? The pressure is up to 95. Great. We've got a rate over 60, pressure over 90. Let's get him on an amiodarone drip, 1 milligram per minute. Get him out of here. Okay? Thank you, guys. That's a megacode. That's the simplest megacode. Okay? So that's how it's going to go on Friday. All right. Any questions? Okay. During the megacode, like you saw here, we went from one rhythm to another. The same thing will happen Friday. You might be in VTAC, then you'll go to VFib, then you'll go back to VTAC. You'll be in PEA. You'll go to pulseless VTAC. They'll go all over the place. Just remember, just change the algorithm. Recognize the arrhythmia, change the algorithm. Start at the top of it and just keep going down. If you're in VFib, or if you're in VTAC, wide complex VTAC here, and there's no pulse. Remember, there are 3 forms of VTAC. There's pulseless, stable, and unstable. If you're in pulseless VTAC, you treat it like VFib. If I've shocked you, I've given you epinephrine, and then you change to VFib, I don't go back up to the top, I'm on the same algorithm. So you would go to amiodarone as your next drug. Okay? Zane.
Can you talk a little bit about epinephrine? It says repeat every 3 to 5 minutes. When are you repeating that, and when are you moving on to amiodarone?
So your first dose of epinephrine, if you give the dose and you shock, and you're doing CPR for 2 minutes, and you check a pulse and there's no pulse, you've only been 2 minutes. Give a dose of amiodarone. You circulate it, you shock them, you do CPR for 2 minutes. Now it's been at least 4 minutes. You can go back to epinephrine.
Okay.
If you have a person who is a young person who you want to save, you need to save, you're going to work hard on them, you might use 10, 15 doses of epinephrine. A little kid in a swimming pool, something like that. If you have a 90-year-old terminal Alzheimer's patient that's not a DNR, you might go through a couple of epinephrines and then call.
How do you bag valve mask with an NG tube in?
How do you bag valve? Well, you pull the NG tube out.
And
This
then
guy.
and then
Yeah.
start. I
Yeah.
figure that.
Yeah, and it would be fine to do it over the NG tube, but I'd probably pull the tube because you don't want it. It's got a bulb on the end of it too, because you don't want to be putting all the air into the abdomen. So, all right. Well, I don't want this. Some of the stuff we can, I'll take with me, but all the rest of the stuff we've opened. Let's move it to the back row, and you can practice on it whenever you want. Okay. All right. Any questions about ACLS on Friday?
Starts at 1.
The test is 50 questions long. You can't miss any more than 8.
It starts at 1, right?
It starts at 1.
It says all day, so I don't know.
I told her to change the time to 1 o'clock.
Okay.
And as I said, hopefully you will not be here at 5. You might be here at 5. Zane.
So I'm just reading through the book. Is there a specific area of the book that you want us to pay more attention to? Obviously, I'm going to look at the algorithms, but looking at all the book, I don't know exactly like what I need to be emphasizing, what I should be focusing on.
Right. The algorithms are the important thing. But if you don't understand something, the book is to help understand. What is waveform capnography? The book will help you understand that.
Okay.
What is VFib? You know, the book will help you understand that.
Will you be
So-
calling it, oh, sorry.
So the test questions are kind of coming from both.
The test questions come from the Heart Association. It's a standardized test. It comes from everything we talked about, from the drugs to the algorithms to the little cheat sheet there. It's everything.
Will you be calling out the rhythm, or will we be expected to look at the
So
monitor?
you're going to have to diagnose it.
Okay.
Yeah. And there are about 10 rhythms on the test that you have to interpret.
Okay.
So make sure that, see, on this thing right here that I'll leave, and turn these things off when you finish because they get hot. There are heart blocks on here. Make sure you know what second and third degree heart blocks look like. Junctional rhythm, agonal rhythm, VFib, VTAC, SVT. I mean, there's a bunch of them on the side here. Okay?
On Thursday, we have class until noon. Would you be able to stay around noon to kind of show everyone the rhythm strips again? Because I feel like not everyone is clear on what's what.
I'm going to be in Ardmore on Thursday. I don't know what time I'll get back. I mean, we can, for just a second, if you want to kind of gather around, we can go over some of these things real quick. Just so you can recognize.
Yeah. Yeah. Will you guys, can we pass that down just so you can see the screen?
Oh, a couple of other things. If you have hot paddles and you don't know what to do with them, if you have hot paddles, if you shocked them and you converted them and you already hit the charge button going to the next shock, now you have hot paddles. You see those two pins right there? You can put these things back into the machine and discharge it into the machine. That's a safe place to do it. The other thing is if you're the one bagging and somebody's using pads or paddles, don't blow oxygen across those things because it can ignite and you can burn up the patient. There are something like 200 patients that are burned up every year because of oxygen. Most of the time it happens in the OR, but anyway. Okay, here we go. What is this right here?
Looks good to me. Normal numbers. 30. 33. Bradycardia.
Third degree block. The R to R interval is the same. The P to P interval is the same. They're just not connected. Okay? You see that? Okay?
Yeah.
Like, oh, just explain it to me. Yeah, I see it now, yeah. All right, what is this? To what? Second degree, type 1. The PR interval is elongating until you drop a beat. Second degree, type 2 is the PR interval stays the same, you just drop beats. Okay?
Can you do one again? Sorry.
What?
Can you do one again?
Okay, what is that? Flutter. The sawtooth waves. Second degree type 1 is you'll see the PR interval elongating until you have a P wave that's not conducted. Okay? What is that? kind of bradycardia. What's the difference between that bradycardia and this bradycardia? The rate is still around 40.
Too much of a P wave on this one.
The first one is sinus bradycardia
Yeah.
because every narrow complex QRS is preceded by a P wave. The next one I showed you was junctional bradycardia because there is no P wave, but you're still dealing with a narrow complex QRS. Okay? So what is this? It's what? Sinus tach. You can see a P wave in there. You see the T wave and there's a notch. That's your P wave. That's sinus tachycardia. How about if there's no pulse here? It's PEA. If there's no pulse, then that's PEA. There's no pulse on this person either. What is it? Idioventricular or agonal. There's no pulse here. You treat it like asystole. Okay? Let's see. If I give you this, and then you see some of these. PVCs. How about that one? Still a PVC, right? But now they're multifocal. Two different unifocal PVCs. As long as you're having not more than 6, it's no big deal. When you start having multifocal PVCs, that means you have multiple areas of irritation in the heart, and that's a more ominous sign. Let one of these dudes land on top of a T wave, and the next thing you know, you're in fib. That's why you suppress ectopy. Okay. I don't have an SVT, but I can sure get your rate up like you saw earlier. SVT, the rate is going to be around 150 or so. Sinus tachycardia, the rate will be up, 120 to 140. You drink a bunch of Red Bulls and you can get your heart rate up like that. SVT, it's over 150. 150 to 180. But once you start getting up that high, then the end diastolic filling starts falling, and that's when you start becoming symptomatic. Okay? So those are the ones you need to be able to recognize on here. There are a whole bunch of other ones on here you can play with at your leisure. Okay? Just remember, this is a live machine.
You stop this thing.
Hey, right here.